We're on the downhill slide now. One day I got a phone call from Kevin McPherson. I'd never met Kevin before, but he was reading my blog and he called me up and he said, "Laura, I like what you're doing. How can I help?" And I said, "You need to be a speaker at my conference." So you got to be careful when you call me. And anyway, Kevin has been working on the redefinition of the operating theater in hospitals, and I've been doing quite a bit of research around healthcare, and I appreciate him coming today and telling the story, because one of the things I think we have not done enough of is building true networks. And I showed you the orbit charts of value networks the other day, and we see every company operating in their own plane, and the whole concept of the last decade was that we were going to work together to really improve value networks, but instead I think we've pushed cost and waste backwards in the supply chain. And so listen to Kevin as he tells the story about building value chains in the hospital. Thank you, Kevin.
See if I can work this thing. There we go. Yeah, so I'll give you a little overview of myself, my career, my experiences, the situation with our company and why we actually had to make some changes, the approach we took to create value, and then a case study and how we did that. So I want to stop for a moment and just say, Laura, thank you for all you do and your team. Just a fabulous event. We all go to many of these conferences, and the synergies and the feeling amongst the members, the sharing of information is fabulous. So myself, I worked 12 years at a company now called Shine Animal Health, 12 years at UPS Healthcare Logistics, where I ran distribution centers. I was in business development for 3 years, and I spent the last 3 years in corporate marketing, developing international cold chain solutions for transportation. I joined Owens & Minor 2.5 years ago because at UPS I had learned a lot on the biopharma healthcare supply chain into distributors, but I knew nothing about the healthcare provider community. So I wanted to get that end-to-end supply chain experience. I have worked in pretty much all of the product sectors, product categories from consumables, disposables, cold chain, vaccines, diagnostic test kits, pharma and biopharma, and I've developed with teams, obviously, supply chains for all of those industry segments. So it's been, and now as I see those down into the hospital environment, you get a real understanding of the end-to-end, actually from manufacturing all the way to point of consumption. Well, let me tell you a little bit about Owens & Minor. Established in 1882, held by 3 families. It is a public company, traded under the symbol OMI. It's about $9 billion in revenue, gross. Net's about $900 million after cost of goods. 2012, we acquired a 3PL in Europe called Movianto. We have 12 distribution centers in 23 distribution centers in 12 countries there. So we're a pure 3PL play in Europe. In the U.S., we're a distributor, and I'll tell you how we changed the strategy for our company there. The company has been a core med-surg distribution company for the past 25 years, and what that means is primarily consumables, gowns, gloves, disposables, vaccines, fluids, but no drugs. Our 3PL division, which I came to run from UPS, was a separate business unit, about $80 million, and we had about 25 pharma and biotech customers. So we ran those two independently to learn the 3PL aspect of the business. Now a little bit about our strategic shift. In the med-surg space, our major competitors went and actually bought up Asian-based manufacturing, and they started using that margin to compete in the healthcare space, compressed our margins materially. And we had to make a strategic shift as a company. So we stepped back and we said, well, what do we have as assets, right? What are we strong in? Well, we have 450 delivery vehicles going into 4,400 hospitals every day in the United States. We have a great reputation for service. The healthcare companies love us. And we have a network, as I'll show you, of 40 distribution centers. So when we had to remake ourselves, we built on that platform, distribution centers, relationships. And the one thing our healthcare provider customers told us, you only bring us about 25% of the products that we use in the hospital. Can you get that to 100? We love you. We want one truck. You guys got to get us more product. So we rebranded ourselves in last year as a supply chain services company. Now think of the impact of this, right? A 130-year-old company with a distributor mentality, which is to buy and resell consumables. So in the distribution center and across the United States, every day is kind of the same, right? You pick the same products, your trucks go out, and they deliver to these hospitals on a very regular schedule. Well, now we're telling the financial community we're a supply chain services company, and what that means is we will develop any type of solution that we can put through that network with any product categories. So we reorganized the company and we built a organizational structure that faces manufacturers. There's a whole sales team there. There's the traditional sales force that faced the healthcare providers. They took our 3PL in my role and they made it a strategic solutions position, and they said, your job is to design solutions from the point of manufacturing to the point of care. And for a hospital network, for a manufacturer, and we don't really care what the financial model is. Meaning we run models where we own the inventory, we run models where the hospital owns the inventory, and we run models where the manufacturer owns the inventory. So I'm going to give you an example of that. So it was a huge strategic shift for our company. And again, it was August of last year, so we're still going through this metamorphosis. So again, just a little bit more about the company and the network. We have 44 distribution centers. And this is a United States example, obviously. We're within 2 hours of 90% of the hospital beds in the country. Those red dots are regional distribution centers, so we run a hub and spoke strategy. And in those regional distribution centers, we're putting the manufacturer's products. Okay? And start thinking about this, right? We're putting the manufacturer's products in those distribution centers. Sometimes they own it, sometimes we own it. And then we'll spoke it out to the distribution centers from there. So the beauty of that, right, is a hospital can, if it's manufacturer owned, and our major product lines like, say, a Covidian, a customer can place an order. We can shift ownership of transfer from the manufacturer right to the provider in one transaction. Inventory never passes through our books. That's one of the strategies, right? If the inventory is owned by the manufacturer, we get the manufacturer to keep it on consignment. We actually can even transition it right to the hospital, and in some cases, put it in the hospital consigned by the manufacturer. So in that model, we take it off the hospital's books. And I'm going to show you that example with an orthopedic implant model that we did. So yeah, just some more facts. 1,400 suppliers, 4,400. I flipped those two. I'm sorry. There's 4,400 hospitals and 1,400 suppliers. We're agnostic to title to inventory, and we generate revenue either by a buy-sell, so buy and markup, or fee-for-service activity, and that varies by customer. And as I mentioned, we're just this week launching implementation of LLamasoft as our network modeling tool. So for major hospital systems, we'll now be able to, and manufacturers obviously, will be able to do network modeling. Today, I'll use an example of Ascension Healthcare in St. Louis. They have 225 hospitals across the United States. We have redundant and duplicative supplies for each one of those hospitals. So every DC stocks the same items, delivers the same thing. Ascension said to us, if you can give me a multi-echelon model, save me money, you can take the profit from that. But they said, you guys have served us the same way for 40 years, and I don't need that. I don't need everything 2 hours away. Take my beds, take my food logistics. I'll give you a 1-month requisition on beds, for example. Put them in a national distribution center and only keep the emergency stuff close to the hospital. So that's an example of some of the modeling we'll be doing. So we're remaking ourselves, right? So we got to say, well, what are we going to do? How do we attack the market, right? We obviously can go to manufacturers, which is low-hanging fruit, and map their supply chain, re-engineer it, remodel it, and there's 10 years worth of work right there if you look at some of the supply networks of the manufacturers and the med device companies. But we said we got to start somewhere, right? So we segmented the market and we took a look at the physician implant market. So if you look on the top right there, it's about a $36 billion market. Have about a 7% compound annual growth rate. So in 2020, it'll be a $64 billion market. So we looked at that and we just saw how extraordinarily inefficient it was. I mean, just you couldn't believe it. But you could certainly understand why the cost of healthcare was as high as it is in this segment when you start to tear it apart. Back to the concepts of the healthcare supply chain. I want to go on a little bit of a tangent here. You'll see there's different markets there. There's orthopedic, there's trauma, there's cardiovascular, there's cosmetic implants. And the interesting thing in healthcare is there are many, many different supply chains within the segment. So the consumables, right, the most efficient on the consumables is direct containers from Asia. Drugs and vaccines go through the major manufacturers. Some get shipped direct. Orthopedics are on consignment in the hospitals, and that's the model we'll talk about. But even with orthopedic, we learned there's multiple models within these subcategories. So the supply chain and service model for reconstructive knees and hips, meaning it's a pre-scheduled hip implant, for example, has one model. Revision, which you already have a knee or a hip and you're going to go get another one that has another supply model because they don't necessarily know what they're going to see when they open up to do the revision. There could be broken bone, so they have another whole instrument kits for that. And the last is trauma, which is the most expensive and difficult, because you don't know what the trauma is going to be, right, until it happens. So there's another whole set of instrumentation and ski lists for those. So a typical trauma surgery will have, a typical orthopedic surgery will have about 10 totes, plastic totes full of instrumentation for one surgery. And they may use 5 or 6 pieces out of that whole thing. All the rest of it turns around and comes back. So cardiovascular, that is another supply chain. In that model, the hospitals buy the items. They pretty much stock those items and replenish them as use. On the orthopedic side, a lot of those kits are brought in just for the surgery. So point being, complex, but once you learn it, you can get to the solution. So we're going after this market now, so we got to go define the problem. And first thing you got to understand about hospitals, they have no money. Well, some of them have a lot of money, but they don't want to let go of it. And even when you create value for them, they don't want to pay for it. Unlike manufacturers who still have some healthy margins, even though those are getting suppressed. So we had to sit down and create value matrices, and determine how we're going to attack this market and what we're going to do. How we're going to create value for the hospital, how we're going to create value for our organization, how we're going to create value for the manufacturer. So we broke the problem down. And here are the supply chain challenges. All orthopedic manufacturers have direct supply models into the hospitals. And they're all terrible. So they're all shipping directly. Some use local contract distributors, but typically they're all shipping directly into the hospitals. And that's all the majors on the private screen, Medtronic, Biomet, Zimmer, Smith & Nephew, etc. So there's redundancy in the overall supply. In the hospital itself, they're stocking, because it's a surgeon preference product line, they're stocking multiples of everything. which is another problem we'll talk about. Combination of insourced and boutique distributors. So some manufacturers ship direct with their own employees and own distribution centers. So now imagine you've got 8 major manufacturers. Each have 30 distribution centers. Owens & Minor has 40 distribution centers. So you quickly get the idea of all the redundancy and the aggregation opportunity that exists there. And some distributors, like Biomet, use a combination of direct employees and distributors. So again, when you're looking for standardization, it's very difficult to get when you're using a combination model like that. Lack limited visibility to the provider and patient data. So manufacturers would have this stuff on consignment scattered all over the country, but very little idea as to when it's being used, how much it's being used, and we'll show you how we solve that. Sales. On the sales side, highly compensated sales reps, so orthopedic reps, spine, primary knees and hips are $200,000 to $250,000 a year jobs. They call them the BMW salespeople. And the hospital administrators know they're paying for that, and the manufacturers themselves understand that's an extraordinarily high cost. And the reason that is because there's a very unique relationship between the sales rep and the physician. They literally control everything. And the sales rep is actually in the surgery with the physician, many times directing him what to do or her to what to do. That's the reason it's so close. But these reps, and these studies have been done, spend 40% of their time doing logistics activities, running down parts, making sure that the kits and instrumentation are there the day before the surgery, checking them in. If there's stockouts, they're running to other hospitals to find parts. So that was one thing that the manufacturers asked us to fix. Get these guys and gals selling instead of doing logistics work. Physician rep relationship, what drives the process, as I mentioned, and the sales reps need technology and visibility tools. So most of those were calling in orders, believe it or not. Some were emailing them in, and they were constantly on the phone with the distribution center, saying, "Hey, do you got my sets ready to go? Are the implants in? Can I come pick them up?" Right? And they had no systematic way to know how the parts and kits were being prepared, and that again was chewing up their time. Financial side, this is probably the biggest part. So. The day sales outstanding in orthopedic surgery across 4 manufacturers that we analyzed is 55 to 85 days. So the joke is, you get a new knee, the guy's out playing golf, right? And the manufacturer, he hasn't even been paid for the product yet. And quickly, the reason that is it's an inefficient process. So the inventory's in consignment in the operating room. It's owned by the manufacturer. When the implant and the surgery is done, they notate what's been consumed. They send a purchase order request to their internal hospital department. The PO comes back as approved. That goes to the manufacturer. The manufacturer 5 days later creates an invoice, sends the invoice back to the hospital, and 30 to 45 days later, the hospital pays the invoice. So in the case of one manufacturer, we identified very easily about $800 million in free cash flow that we could save for them by just moving the DSO down to what our standard is 19 days for the hospitals. 2 to 4 inventory turns is typical. Heavy working capital in inventory, and that's one of the issues the major manufacturers need to solve. Antiquated demand planning tools. Again, I mentioned those. There's literally, it's the sales rep sitting down with the materials manager and saying, okay, how much inventory should we keep? How many implants this size, that size? No systematic way or math tools or planning tools that they're working with. 3 to 5% inventory loss, outdates, obsolescence. So again, a manufacturer has this product scattered all over the country. A sales rep comes in the case of the biggest one, it's a $16 billion company, manufacturer we're working with. They cycle count the inventory once a quarter, and they adjust it up or down once a year. And high transportation costs, this is the other one. So I mentioned the redundant manufacturers. All of them, all the majors, every day are air shipping stuff into the hospitals. And it's a buy one, use one. So in the case of the Detroit hospital, we actually went to the dock, and from one manufacturer, there was 40 shipments of air shipments in one day. And that generated 40 purchase orders, 40 invoices, and 40 payments. It's crazy, but a good opportunity, right? So that's the implant manufacturer's problem, right, in this value matrix we did. Now let's turn to the healthcare providers. What's their problem here? Well, they got it pretty good, right, because the rep's doing all the work. They don't have to own the inventory. All they care about is don't miss a surgery, don't make the doctor mad. That's when all hell breaks loose. But the problem with the hospital is the surgeon preference is driving SKU proliferation. So doctors king, orthopedic guys king, sales reps king. So if you have 25 surgeons in your hospital system and each one of them wants to use a different manufacturer, they're stocking all those. And it's getting to the point where a knee replacement, an implant is a knee implant. It's getting very genericized today. So there's not a lot of innovation in those much anymore. So they've got a ton of SKUs to deal with. Sales reps in the hospitals and the ORs. Administrators want them out. There was another study done that the cost of an average surgery, implant surgery, goes up 20% when the sales rep's in the room. Because he's saying, use more screws. Put another, brace or implant or rod in that bone, right? And he's actually telling the doc what to do while he's standing there. SKU redundancy, I mentioned that. Hospitals want to get to a formulary. So as compensation moves and reimbursements move to patient-based outcomes, the more progressive hospitals are going to start bidding out their orthopedics, and they're going to be looking at manufacturers and asking things like, how many recalls have you had? What's your innovation in technology? How many SKUs do you have? Those types of things. And they'll limit the number of manufacturers and product lines they're going to have in their hospital. Warehouse labor costs are high, not only for us but for the manufacturer or the providers in the incidents where they do stock the items, right? So it's simple. They've got 8 manufacturers. Each one's got 15,000 SKUs, and they're stocking all of those. Redundant. Contract pricing management was another thing we had to solve. So I'm getting a little deep here, but when you're in that surgery, there are billing codes for the different types of procedures. And if you do an adaptation off that billing code or that procedure, or you add implants to that surgery, now you have to recalculate and reprice. So hospitals are just terrible at matching what they bill patients with what the contracts are with the manufacturers for what they're supposed to pay. So they don't administrate those contracts and keep them up to date. That contributes to that 55 DSO cycle, right? So I did a surgery, I recorded everything. Hey, wait, we don't have a price for this one size pin. So that, it goes and sits there in a pile till they call the sales rep and say, what are you going to charge us for that pin? 4 or 5 days more to the cycle. Whoops, sorry. Erratic supply. And alternate sourcing is difficult. So again, it's just a function of the SKU proliferation and the number of product lines. If they're out of something or something doesn't show up for a surgery, there's no systematic way for the hospital systems to look across the inventory. So we provided visibility in that solution. Disaster planning is big. I bring that up because after 9/11, all major hospital systems, particularly in the New York area, are keeping redundant inventories. And that was a problem that the manufacturers didn't want to support, but it's a need the providers have. And then the hospitals are saying, help us, right? Owens & Minor, you're in here every day. You're a distributor. You see all these manufacturers. You need to come up with a solution to help the industry here, help the manufacturers as well as us as the healthcare providers. So the solution, so what do? And what did the market need? So we needed to reduce a significant amount of inventory for the manufacturers. We need to clean up the manufacturer consigned inventory. We needed to reduce freight, all that air freight shipment. We had to give 100% visibility to the consumption data and share that back to the manufacturers so they could do a better planning. We had to standardize the processes, particularly with the sales reps. None of those processes are documented on how a sales rep takes an order, gets it from the physician. It's kind of shocking, but the average time from when they schedule surgeries anywhere from 6 to 8 weeks out, a reconstructive, but the distribution center typically finds out about the order 24 to 48 hours before. Then they start scrambling. So we're asking, why is that, right? Well, I don't know. Well, Doc, will you share information with us when you schedule these surgeries? Yeah. Well, why haven't you done that? Well, you ready for this? No one ever asked me. Nobody ever asked me. So in standardized process, and then we wanted to improve recall management capability too. So as crazy as this is, you guys, many companies don't even record the serial numbers that are being implanted in patients. And the records are scattered. The process is not standardized. But it is what it is. Salesforce now, we want to increase the rep productivity. We want to get the reps selling and not doing supply chain activity. We want to give them 24/7 visibility to the inventory sets, right? And I'll show you how we did that through some signaling from our warehouse management system. Financial, again, we're bringing this to the marketplace now. PO on the day of the procedure, 15 to 20 day reduction in order cycle time, and cash cycle time, and the ability to cover more cases with less inventory and fewer reps. So, example, a primary knee and hip, 10 totes, about $50,000 to $55,000 worth of inventory at cost. The cycle time for one set was about 96 hours, and we were able to design that down to 48. So that's obviously, right, it's 50% reduction in inventory if you can keep doing that planning relative to the surgery schedule. So that's what we did. That's what the market needed, and here was our solution. So simplistically, what we did, we went out and we said, okay, we got 40 distribution centers. We're going to eliminate your stocking centers. We don't need those anymore. We're going to put the inventory in our distribution centers. We're going to set up par levels at both the hospital and our distribution center, and we're going to manage the inventory in the hospital. So now we're going in doing daily counts and inventory verifications. We're triggering par levels on our technology that we put in the hospital, signaling it back to our distribution centers who are delivering to these hospitals anyway, right? So now the inventory is riding on a truck that's already going there. It's being ordered with their other supplies, so we cut all the purchase order volume down and all the cost of purchase orders because we just added it to our total order concept. Again, we put par levels on our side. We send replenishment orders back to the manufacturer, and they send us a weekly ground shipment into our distribution centers. So we took all that stuff out of the air, weekly shipment on the ground. We clean up the inventory management at the hospital. We now have par levels in place. And then through our visibility tools in our warehouse management and our ERP system, we were able to show the manufacturers daily consumption of inventory. And I'm going to tell you about another really interesting model in the spirit of collaboration, right? And this is a healthcare story too, if I got enough time. Little company in New York called Paradigm Spine, innovative company, took spinal stenosis surgery, which is about a $70,000 procedure and about 7,000 SKUs that go in the operating room. They got it down to a little kit about this big with 13 pieces in it. And that $17,000 surgery, they got down to $15,000. But they said, I don't want to use the traditional model. I want to go direct to the hospitals. And we're like, direct to the hospital? Surgery? Yeah, that's what I want to do. So we designed a solution for them where we ship the kits on consignment into the hospitals. They weren't very expensive. The hospitals now send us directly what they call charge slips, which are basically the slips that they produce after the surgery and recording which implants they used in the surgery. They send those to us electronically, and we send the replenishment implants back to the hospital. And then we record the in-transit inventory as well as keep a perpetual inventory balance of what's at the hospitals. So from a financial perspective, we can tell Paradigm Spine how much inventory they had in the field at any given time, what's consumed every day, and they manufacture in Germany. So every morning Germany wakes up and they can see the entire consumption in the U.S. the following morning, and they can do their manufacturing planning to that. That's probably the best example I could share with you of really doing a disruptive of model in orthopedics, and it works fabulously. Now the beauty of it is there's only about 3,000 spine surgeons in the U.S., so it was a very controlled population in which Paradigm could work with. So they identified the surgeons they want to work with, they trained them, they got them to sign off contractually on the process that they would use, and the doctor supported in the hospital making sure this process was implemented. Our DSO in that model, again, it's a spine, it's an implant model. Our DSO for this manufacturer, because we do the billing on behalf of Paradigm to the hospital, is 22 days. So it can be done. All right? This just shows, again, a depiction of the model. I won't go through it in detail, but what I want to point out on the bottom there is what we did with the reps. So to get the reps back on the road and get the what they call trunk stock, for those of you in healthcare, that's the golden goose of sales reps, right? They've got tens of thousands of dollars in their truck every day in the back of their car. So we pulled that trunk stock out of the rep, and boy, were they nervous. We did this in a Texas marketplace. But we set up pulses, alerts for all the major steps in the process that the sales reps wanted to see. So when we designed this, they were our customer, right? And they were very nervous about not having their hands on the inventory, because if you miss a surgery, it's the worst possible thing that can happen. And they could lose the product line, lose the business, and it'll take them years to get the business back. So all the key milestones that they wanted to see, we set up alerts in our systems and sent them texts and emails. We've soft allocated your kits for Dr. Jones's Thursday surgery. We've hard allocated the kits. They're prepped on the dock and ready to ship. They shipped. They were delivered in the hospital, and those reps typically go in 24 hours before and physically make sure that everything's there. So once we started giving them all those alerts and we proved that it could work, we put the sales rep back to selling and took them out of logistics activity. And again, it's just using technology to replace poor processes. So what value did we create? First, to the providers, we got the product to the floor a half a day sooner. So in the current model, everything flies in, hits their dock 10:30 in the morning, sort all the corrugate, sort the implants, put them on a cart, get them up to the floor. It's 1 o'clock in the afternoon before they're up in the OR. Now we had them there on our delivery vehicles 4:35 in the morning. All the corrugate was removed, and the sustainability issues here. A lot of hospitals are now mandating no corrugate in the hospital is a new trend. So we have to clean all that stuff up. It put us in a position to actually go the next step, which is to build surgeon preference case carts. So we're working with a project, I can talk about this one, in Zimmer, in Lancaster, Pennsylvania, where we're actually building all the components for the surgery for that specific surgeon. So if he uses certain instrumentation, we have a menu or a preference card. We know what types of implants he's going to use because we get the surgery schedule, and we'll build an actual procedure cart, everything that needs. So it goes into the hospital, all prepared, no corrugate, goes right up to the surgery floor, into the surgery, and everything's sterile. So reduced receiving and inventory control labor. We eliminated parcel receipts. I mentioned that before. Pathway to procedural kitting. I mentioned that. And it's scalable as well. So it'll put the healthcare providers in a position to go to a formulary now, because all the systems are in place. What did it do for Owens & Minor? Right, expanded our total offering. We weren't a med-surg company now, just out there banging heads on margin, right? Because that's all it is a margin grab. And now we're offering some value. We leveraged our private fleet a little bit better, got better return on invested capital on our private fleet, leveraged all of our inventory team. We have 88 inventory counters across the United States in hospitals already, so we were able to leverage those individuals, and a pathway for reduced cost of care. So that was kind of our moral obligation on the providers asking us to do more for them. What the manufacturers get in this one manufacturer, 20-day reduction in DSO, received the total supply chain visibility, which was one of their mandates. They divested of the inventory risk. So in that loss obsolescence I mentioned, they about 3% of the surgeries they were missing because of stockouts. And when that happens, a competing product goes into that surgery, and they lose the surgery. Increased working capital, both from an inventory standpoint and a DSO. Increase the return on investment for the sales reps and PR. So the manufacturer is actually, we're writing white papers to them, and they're going to be promoting this service as a creativity and innovation. So they got some PR out of that. That's the presentation. I'll open it up for questions, comments, thoughts.
Well, I'm going to start you out.
Okay.
So what do you think about additive manufacturing in the medical device industry? You know, I was talking to somebody the other day that said, 3D scan and be able to do a hip or a knee. How far away do you think we are on that, or do you think that's ever going to be the reality?
We had that conversation with one manufacturer, and obviously there's regulatory aspects, right? Everything has to be approved. So
right.
If you're going to make something on demand, the whole process is going to have to be FDA approved and sanctioned, and that's years out there.
Yeah.
And then all the controls around, the quality controls around it. So we don't see it coming for a long time, but they are getting better in terms of optimizing the inventory they have. So last year, even, you would go into a surgery, and if you had to replace a patella, they'd kick of 8 patellas, and you didn't know which one you needed until you got in there. Now they'll do an MRI. They'll get it within one size up or down, so you can now take 3 in instead of 8. So they're doing a lot of that predictive work around the surgery to help improve the efficiency.
So how about standardization of medical device? Where do you see that going? UDI standards, GS1 standards?
Gonna happen.
Yeah.
Right? I mean, the process has been set. The rules have been set. The tracking you're referring to, the whole use tracking and recall management, that's all going to happen, and we're already building it.
So when do you think it'll happen? I mean, if we imagine the supply chain of the future, how long is it going to take us?
Next year.
Oh, really? Okay.
Yeah.
So you think
they're writing the rules for it now.
Mm-hmm. Okay. What questions do we have for Kevin?
Roddy,
you know anything about this industry? Huh?
Medtronic at one stage were experimenting with RFID in cabinets in the surgeries, and basically the kits had RFID, and as you pulled it out, it automatically read. Where did that go? Because that was being done 4 years ago.
See, that's interesting, and this was part of the topic we wanted to talk about. So we've met with them on that, and they have not been able to make that happen. And it's for a couple reasons. One, they cannot get compliance in the hospitals. So the biggest thing about, if you go in and see these cabinets, RFID cabinets or Pyxis units or WaveMark cabinets, the biggest issue is that the nurses won't use them. They won't use them effectively. You'll see that you'll go in, they're supposed to record inventory, record lot and all that. You'll see that somebody had the key, opened it up, and was taking stuff out. Or they didn't use their code, or they're using the other nurse's code, or something like that. But we're experimenting with it with a company called Helios, and we think we can add value in the spirit of this because we can change the game. We're in every hospital. What the hospitals say if Medtronic goes in, you're only one manufacturer. I'm not doing that for you. If I do it for you, I got to do it for everybody. So unless you guys, manufacturers, can get together and figure out how to do it, that'd be great. So we think we can add value because when we develop this new model, up in that value prop, look, if you want the product half a day earlier, you want a case cart build, you want this, we need you to agree to put this inventory system in, right? And the nice selling message on that is, A, they'll probably agree to do it. B, we can almost mandate it because you don't own the hospital inventory. We're doing this for the manufacturer. If you owned it, I would understand. But we're accountable for it. So we're asking your consent to bring this piece of equipment in. So in the Helios model that we're looking at, there would be a reader in the storeroom. So every time the unit went in through the door or came out through the door, we'd record that. But we're still a ways away from actually defining how that's going to make sense relative to some of the next best alternatives, right? So if we have to have inventory people in the field, can we take them out? Probably not, right? Because we could, yeah. We need mass, we need aggregation, we need volume in order for it to work. So we would need multiple manufacturers, in our way of thinking, to agree to do it, or at least get the hospital to agree to do it, and then we could do it on their behalf. But you know the issues, right? You can't put RFID tags and adulterate packaging on devices, unless you put plastic over them. So there's a lot of that stuff we have to get over too. And Medtronic at this point, last conversation we had with them a month ago, is they're not in a position to start embedding those chips into packaging.
Because when you think you don't have the problem that the consumer goods industry has, where the unit costs are so low that you can't justify an RFID.
Right.
That's right.
You've got expensive kits, so sticking in an RFID tag and having some sort of inventory logging system which codes stuff.
Yep.
Just seems crazy. But
and it all seems intuitive, but when like a lot of things, when you get down to it, you say, what is the problem we're trying to solve? If it's just to account for inventory, well, we got cycle counters in that. So what's it going to cost to put the tags on, the labor to do that, put the readers in? We got the cost, I think, around $20,000 per hospital, which isn't too bad. But what's the payoff for that, and who's going to pay that off, right? We've got to find where that value is going to come from to do the payoff. And the hospital don't own the inventory, right? So in this case, they don't really care, but the manufacturers do. So there's where it gets complex, right? Because in another conversation with another manufacturer, major manufacturer, you know what they said?
What?
Why don't you own the inventory?
And you said, oh.
Well, we said, we'll talk about that.
Okay.
Right? Because it's what we do already. We're already billing. We're already invoicing. We said, well, if we take on, I'll pick a number, $8 billion of working capital onto our books, we're going to charge you 10, 12% on that, and then that's going to blow the value prop of the model. So this is really interesting because the manufacturer said, well, what if we issued a 0% note to finance the inventory?
And
we said, is that legal?
And
that conversation's ongoing.
yeah. Well, maybe.
But that would solve the problem, right? I mean, we
get
didn't
us
blow the
closer.
financial model. Obviously, we're using their working capital,
Yeah.
right? Because they do actually have a lower cost of capital than we do. We're not have to put a margin. We solve that problem that way. And ironically, it was going to come down to they're not really going to float us alone. They're going to give us a 60-day billing term. Mm-hmm. So if we're successful in getting our 19-day collection activity, I mean, we could maybe float $8 billion for 20 days a month.
All right. I think we got a question here. Go ahead.
Yes. Kevin, Roger, University of Wisconsin-Madison, excellent talk. So that last example you gave was where you put up the value created slide. That was for the spinal implant company?
It was cardiovascular.
Cardiovascular. So
Yeah.
my question has to do with, I think there's a lot of great lessons for supply chain leaders, even within enterprises, from what you're doing there. That's a custom supply chain that you made for that product, right? I mean, all the way from the manufacturer to the end. How many of those supply chains do you think you run through your company? I mean, like, that's a segmented supply chain. There's a lot of different supply chains you would run.
Yeah, so I actually keep a map of those, and we now have 15. We have 15 different supply chains that we're offering. So like this one, we can just layer it, right? So that's the orthopedic solution. But there's 15 different models. Because remember, we're flipping inventory ownership on a lot of these, right? So there's some adaptations on the same ones.
Karen.
Kevin, Laura asked a question about standards, unique device identification. You referenced the rule. By next September, all implantable devices will have to have a UDI.
There you go.
One of the challenges I've been working with Pew and Brookings and FDA and Duke on is the fact that you don't have to mark the implantable devices. And for orthopedic trays, you mentioned the complexity. Mm-hmm. We actually take the product out of the packaging, put it in those trays that are set up for the convenience or the efficiency of the surgery. There's no longer a way to capture the UDI and the data on what was actually consumed and implanted. Have you considered how to solve that one? Because we're all trying to figure it out.
Nothing like getting put on the spot on stage, right?
So I think you know this particularly, Karen. We have a technology called QSight, and in this model that I'm talking about, we're capturing lot serial and expiration at the point of surgery. The patient data is captured as well, but obviously for HIPAA reasons, we don't see that. So we have a solution for that, but I'm not sure yet whether it's scalable, whether the one we have is scalable, because it involves us obviously getting that technology into the hospital. And as you know, they don't like new technology. They don't want to interface to new systems, right? So there's what we call QSight Lite, which is basically you have to manually input the information in. And then there's the integrated QSight Heavy, which is the full integration model. But we have the technology. Again, it's back to compliance and something we can scale.
So I have a thought. I mean, if companies like P&G can use video cameras and CBT manufacturers use cameras to look at labels on products that are on the wrong shelf, why can't you use camera technology for that sort of stuff?
Because the product isn't labeled once it goes into the tray.
Right.
Because if there's no direct marking on the product, it's been removed from the packaging. It's actually sitting in a tray. All the screws, all the plates, all the implants.
And they're not distinct.
FDA can't figure
Keep thinking about it, supply
I bet
chain
you this room
transformation.
can solve it.
Yeah, maybe it'll be a spark. Okay, thank you so much for coming.
You're welcome.
Thank you.